Hi, everyone. Thank you for joining. My name is Florence Momplaisir. I'm an assistant professor in the Division of Infectious Diseases, and I'm presenting the results of my pilot entitled Evaluating Women's Perception and Interest in PrEP During the Perinatal Period. So I have no conflicts of interest. I'm going to start just by providing a global perspective of the HIV epidemic among women. So there are about 40 million people living with HIV worldwide, and a little over half of them are women. And the majority of new cases occur in Africa, particularly in Southern and Eastern Africa. And globally, about 1.3 million women with HIV become pregnant each year. So in the US, fortunately, HIV incidence is going down among the majority of demographic groups, including women. However, racial disparities continue to persist, with the majority of infections occurring among Black African American women, and the majority of infection occurring through heterosexual contact. Now, to dwell further into the demographic characteristics of new HIV diagnoses in the women, you can see that the majority of infections occur among women of childbearing age, within women in their 20s and 30s. And again, the majority of infections occur through unprotected sex. So these are women who are accessing care for their pap smears, for STI testing and treatment, for contraception, or for prenatal care. And speaking of pregnancy, and particularly the postpartum period, as an opportunity to intervene for HIV prevention, this slide shows the increased risk of HIV acquisition in pregnancy and postpartum. And as you can see, women during pregnancy have a close to 5 times higher fold risk of HIV infection and 3 times higher for women in the postpartum period compared to women who are outside of pregnancy and postpartum. And the increased incidence is attributed to both behavioral and biological changes during pregnancy. So without the incentive to avoid pregnancy, condom use is decreased for women during pregnancy. There's also an increased risk due to biological susceptibility due to genital tract inflammation and alteration of the vaginal microbiome and decreased integrity of the vaginal epithelium. So this slide showed the results of meta-analysis of 4 PrEP studies, and showing again that significant protection is seen for women when adherence is high. And this is something widely and consistently shown across studies, particularly for cisgender women. And I want to bring your attention to the last 4 rows of this figure, showing that for women who have poor adherence to PrEP, particularly when adherence is 25% or below, PrEP is not effective, and that effectiveness really increases with moderate and particularly with high adherence. And we know that PrEP is safe in pregnancy. Results of the partner PrEP study and demonstration projects show that there's no difference in pregnancy incidence, congenital abnormalities, and adverse pregnancy outcomes as measured by birth outcomes and infant growth during the first year of life, comparing women receiving tenofovir and emtricitabine compared to women who are not receiving tenofovir or emtricitabine during pregnancy. And we're all excited about the prospect of using long-acting injectable PrEP. Obviously, the trials did not include pregnant women, but this is a very attractable option for women in the postpartum period, particularly because of the disruption of daily routine, which impair adherence to antiretroviral therapy. So again, in summary, the rationale for using PrEP in pregnancy and the postpartum period is that PrEP can effectively reduce the risk of HIV acquisition to the mother and her baby. And we know that acquiring HIV during pregnancy is conveys a high risk of transmission to the baby. And PrEP provides the opportunity for the woman to be in control of her own HIV risk. And this is particularly the case when the partner status is unknown, which happens pretty often. And PrEP is found to be safe for the mother and her baby. So these are all reasons to be offering and discussing PrEP for women during pregnancy and the postpartum period. So now I'm moving on to the actual study. So there are limited data on the acceptability of oral PrEP during pregnancy and limited data on acceptability of long-acting injectable PrEP for women in the postpartum period. And so the purpose of this study is to assess knowledge, interest, belief, and outcome expectancy around oral PrEP in pregnancy and the use of a long-acting injectable of PrEP in the postpartum period. And we also wanted to assess the acceptability and preference of oral PrEP versus long-acting injectable PrEP. So we conducted 20 individual in-depth interviews of pregnant women with a STI diagnosis during pregnancy or the preceding year. And the inclusion criteria were that women had to be in care at the Penn Center, be 14 years of age or older, and English speaking, and being able to provide informed consent for the interview. So we completed a chart review of patients who were scheduled for high-risk clinic on Tuesdays to determine who was eligible for the study. And eligible participants were called to assess interest in participating. And women were asked to be in a private room for the interviews, and the interviews were conducted in blue jeans and lasted in average about 60 minutes and were followed by a red cap questionnaire, and participants were compensated for participating in the interview. So in general, in terms of the survey instrument itself, we started by providing a short summary of what PrEP was and before asking about the acceptability of PrEP. We included questions such as, what do you think about using PrEP in general? And this was followed by probes on outcome expectancy, so asking about what did they think was good about it or what did they think was bad about it. And we also asked about what they thought about using PrEP, particularly in pregnancy. And based off of the information of oral PrEP provided, whether this would be an option that they would be willing to use if it was available at no cost to them, because we didn't want cost to be a barrier. We also ask about their comfort of having an informed conversation with their HIV provider about using PrEP in pregnancy. So between August of 2020 and April of this year, 117 women were eligible by chart review, and 97, so about 83% of them were reached by phone. 17 declined, and the rest asked us to call back, and we were unable to reach them, and 20 completed the interview. So among participants who completed the interview, the average age was 23 with a minimum of 16 and a maximum of 31. The majority were Black African American, 100% US born, about half had a high school education or GED, and a little over half were using Medicaid as health insurance. The number of previous pregnancy prior to the index pregnancy was about 2. 3/4 of them reported that the index pregnancy was unplanned. And 95% felt that they were not at risk for HIV. 50% reported having unprotected sex with more than one partner, and 80% reported having a STI diagnosis. So in terms of our results around the acceptability of PrEP during pregnancy, so 52% of participants were opposed to taking either oral or injectable PrEP during pregnancy. 38% were willing to use PrEP, and about half thought that oral PrEP was acceptable, and the other half thought that they preferred the injectable long-acting PrEP, and 10% were unsure. Now, when thinking about reasons or facilitators for PrEP acceptability, being in control of one's HIV risk was a reason for PrEP acceptability. And this participant said, I feel it's a smart thing to do because some people are careless and stuff like that. And to make sure you don't catch HIV, that's very smart, especially if you take it every day and you can't catch it. You can catch HIV from taking it every day. And some women felt that they should be educated on their HIV risk and that PrEP should be offered for women deemed at risk for HIV. So this participant said, I think if you found out that you're pregnant and that they do your blood work and feel that you're at high risk of getting HIV, I feel like they should give you PrEP as a medication or tell you about it and give you options. Another reason for PrEP acceptability was the prevention of HIV transmission to the baby. However, only 2 participants reported this as a reason to be on PrEP. In general, there was a lack of understanding that HIV could be transmitted to the baby. And one participant said, I don't know if people have HIV, do they pass it on to their baby? I feel like you could take PrEP and then you lower the risk of the baby getting HIV. That's a great thing, but I'm not sure. I don't know this stuff. So in general, there was a sense that it would be a great option to reduce the risk, but there was a lack of knowledge about the risk of transmission. And now pivoting to barriers to PrEP acceptability, poor knowledge of PrEP was a very strong theme that came up across most of the interviews. So 67 of participants had not heard of PrEP prior to the interviews. And those who were aware of PrEP desired additional information, and only 2 had a recent conversation with their obstetrician regarding PrEP. And those 2 conversations actually took place after grand rounds that I had presented the preliminary results of our project to the OBGYN group, and they had a follow-up. They started offering PrEP as an option for their patients. So one participant said, honestly, this is my first time hearing about PrEP. So that's why I wanted to do the study, because I like finding out new things and learning new things. In general, there was a low risk of risk perception, and I showed that with the results of the questionnaire. But in our qualitative interviews, we delve into this a little bit more. And 81% felt that they were not at risk for HIV. 14% felt unsure about their risk, and 5% felt that they were vulnerable to HIV. So their personal assessment, their low risk status was based on their current sexual behavior and also on the perceptions about their partner's sexual behaviors. So one participant said, I don't think I'm at risk. I hope I'm not at risk. I only had one sexual partner, and that's my own. My daughter's father, he's my first, my virginity. So I never had sex with anybody else, and I hope he's not having sex with anybody else. I don't do drugs, I don't share needles or any of those things. Another barrier to PrEP acceptability was related to concerns regarding side effects and risk to the baby. So in general, women wanted to restrict medications in pregnancy to the absolute essential. They felt also that PrEP was a new medication and that the safety profile, particularly for the baby, was not robust. And one participant said, I don't know, because I've always learned that for pregnancy, the only thing you're really supposed to do is to take prenatals and Tylenol. Another participant said, I wouldn't use it because I don't know the side effects or the effects that it's going to have. So just very cautious while I'm pregnant. So I wouldn't. Another barrier was, particularly around oral PrEP, was the need for good adherence in order to have protected levels. And women, throughout many interviews, naturally shifted comparing PrEP to contraceptive methods. And using oral contraception as a reference, some women worried that they would not be able to adhere to a daily pill. So one participant said, I would forget it, like I forget to take the pills as much as I should. Like I don't feel like taking the pill every day, so I don't. It's just, I'm just not doing it. Again, because this participant wasn't consistent with her oral contraceptive pill, she felt that she wouldn't be consistent with oral PrEP. Now, moving on to injectable PrEP, particularly for women in the postpartum period, of the 8 who were hypothetically willing to use PrEP in pregnancy, about half would prefer using injectable PrEP over oral PrEP. And the reasons for acceptability were not having to remember to take a medication daily, not liking to take the pills, health beliefs associated with the injectables, like the perception that it would work better or last longer because it's an injectable, and women's hypothetical PrEP preferences depending on their lifestyles, preferences, and habits. So in general, we came in particularly thinking that there would be excitement and high acceptability for injectable PrEP, and what we really saw was that the acceptability was more mixed, and it was really based on their preferences regarding pill taking. So one participant said, I prefer it over the pills because I hate taking pills, honestly, but I prefer that over the pill. I'll say I think it'll work and get inside your system more effective than the pill. I think it would get it faster instead of taking the pill. Again, this perception that it would work faster because it's an injectable. Like when I plan on not having a baby, I plan on getting an IUD. I don't want to take the pill and that I got to think about every day. If I get the IUD that lasts 5 years, I don't have to worry about it. So again, the natural shift of comparing PrEP modalities to modalities of contraception. And yeah, 8 weeks, that's me getting double shot. And here this woman is talking about the depot shot every 4 weeks or something like that. So she's basically linking getting the shot to getting the injectable PrEP. Again, other barriers to injectable PrEPs were not liking needles, feeling that an injection is more intrusive, especially when there's limited understanding of what's being injected. And one participant said, I would rather do oral than do an injection. I don't know, just inject anything with a needle, especially in my butt, wouldn't be for me now. Oral pill, I could do that. Another participant said, I don't like injecting things, like people inject me with stuff because I don't really know what it is, so I don't prefer any injection. So there was a sense that getting an injection is intrusive, they're not sure what they're getting, so the oral pill would be a better option for them. In terms of sources of education for PrEP, 6 participants had heard of PrEP before the study. 4 reported that they learned about it through awareness campaigns through television, high school sex ed classes, and family members. And 2 became aware through conversation with their provider. In general, women wanted their provider to tell them about PrEP and wanted the recommendation to come from them, again, because they saw their providers as a trusted source of information. And one participant said, I mean, that's their job. So if I would need help, I would rather go to somebody whose job it is. So the information they tell me, I feel confident in talking to them about certain stuff because they're going to tell me the truth, and that's going to give me the information about it. So in summary, Women in Principle supported the idea of initiating PrEP for HIV prevention. Counseling for PrEP needs to start with a conversation about HIV risk and the risk of in utero transmission, and there was in general very poor knowledge around this. Again, the role of risk assessment, particularly with risk perception, is unclear. But women who are open to hearing about PrEP, again, needs to be informed about the side effects and the risk during pregnancy for themselves and their baby, and be reassured about the safety profile of PrEP during pregnancy. And like contraception, it's important not to use a one-size-fits-all approach when talking about PrEP, and women should really make this an informed decision based on their lifestyle and conversation with their providers. We have started in the OBGYN setting on a protocol around including in the EMR prompts to pass PrEP with the patients based on their past STI diagnoses, and hoping that we continue this work with integrating PrEP in prenatal care. Finally, I'd like to acknowledge my OB colleagues and also other colleagues in our division working on this project, and investigators at Drexel who have also been closely involved with the analysis of the transcripts. Thank you very much, and I'll see if there are any questions.
Thank you.
Thank you, Florence. It was great. I have a question for you. You may have data about this. How big is the problem of incident HIV during pregnancy? So among the dozens I know that you follow every year, around 20 to 30 people with pregnancy and HIV. How many are diagnosed during pregnancy? How many is the second HIV test during pregnancy? Bill or you might know that data. Because my perception is probably a relatively very rare event. Are you really thinking in giving PrEP during pregnancy or after pregnancy?
Yeah, so that's a very good question, Pablo. I think based on because again, the majority of my patient panel, all women and women of childbearing age, and I have to say that based on the profile, I would say about 75% of women are diagnosed during pregnancy, but not because it's an incident conversion. It's just that they get tested and they have the opportunity to receive routine testing in pregnancy on a consistent basis. Again, women of childbearing age, other than pregnancy or specific issues, don't access primary care on a routine basis. So pregnancy is a perfect opportunity for to get tested, honestly, for the first time for HIV. You're right. The numbers are pretty low in terms of acquiring HIV during pregnancy. I don't know the exact numbers, but it's a rare event in general. Based on the FACP review that we hold during the health, because we hold regular meetings where we review cases of women during pregnancy. In the past 5 years, I would say that there were probably 3 women who acquired HIV during pregnancy that we reviewed in Philadelphia.
The initial test was negative and the subsequent one was positive.
Exactly.
Florence, I have a question. It's really fascinating and incredibly important. And even if HIV infection during pregnancy is not that common, I guess that's a way to enter these women into the PrEP system or cascade. So something that really struck me is that all of these women were pregnant and 80% had had a previous STI. yet 80% perceive themselves to be at low risk for HIV infection. So as I think very superficially about where are the gaps in terms of PrEP, it's the self-perception of risk. I wonder if you could unpack that a little bit and see what your thoughts are on this. All of the beating on take PrEP isn't going to do anything if people don't consider themselves at risk and misperceive in that way.
Yes, I agree with you, Ron. And I think the work around, linking risk perception with need of PrEP is an important one. I think the higher yield in terms of, if you think of strategies, right? I think it might be better to routinize and when I say to provide and have conversations about starting PrEP and normalizing the process, honestly, in prenatal care instead of focusing on individual risk assessment. I have to say that the women that we included in the study, all of them had an actual STI diagnosis. It just happens that 80% of them remembered having an STI diagnosis. Based on that, again, there is a clear disconnect, right, around risk perception and actual risk. And so that's why I think it's important to even go beyond the risk perception and just say, okay, these are the women who qualify for PrEP, particularly if you had a STI diagnosis during pregnancy or the year before you qualify. Instead of asking about their individual risk, let's just standardize the process, remove provider bias, remove any sort of, risk assessment on the patients and have those conversations on a sort of routine basis with everyone and see where, if we can increase the buy-in. Because based on our interviews, even, women who perceive themselves at low risk, they thought, well, if there is a chance that I might be at higher risk, and if there's a theoretical benefit to my baby, why not try it? And so I think that's why it's important to think about having those conversations really with routinely during prenatal care. Hi, Kate.
Hey, that was great, Florence. Can I ask, because I hear a lot from, in clinical trial group discussions, the concern that we don't have good safety data in pregnant women and or women of childbearing or people of childbearing potential. And so as you have these important discussions about risk benefit with pregnant individuals, what are there good safety data for either injectable or oral PrEP, and or if not, how do we broach that uncertainty as the very slow moving clinical trials world actually gets those data?
Yeah, so the majority of the data that we have in terms of safety of PrEP is extrapolated from HIV positive women, right? Like a large number of HIV positive women are on a tenofovir backbone regimen. And in general, the safety profile based on that is pretty reassuring. And the other studies that we have are really based on demonstration project or secondary data analysis from, randomized control trial where women became pregnant. So in general, yes, I think we need more data. But I think the body of evidence that we have was reassuring enough because I sit on the HHS panel and was a co-writer for the PrEP section that came out this year for women in pregnancy. And just by reviewing the data, I think there was enough evidence to say that the benefits outweigh the risk in general. So the current recommendation is to offer PrEP in pregnancy based on that. But I agree, more data is needed.
And we're having a presentation of that on Thursday at 8 a.m. ID Grand Rounds by Ellie Caniglia, who's a perinatal epidemiologist who's coming to Penn from NYU, and she'll be talking about this data from Botswana. So please tune in if you can, 8 a.m. next Thursday.
I
Thanks,
just,
Robert.
I'd like to also, I'd like to say that the issue of risk perception is kind of universal. It's if you look at Dan Resnick's recent publication, you know, MSM also stopped taking PrEP because they felt they weren't at risk, especially the ones who got infected after starting PrEP. So, you know, I think it's a really important concept for all of us that we've historically lumped people into high-risk groups and low-risk groups, and that assumes that risk is a stable construct, and it's not. Just like pregnancy, most of these women said that they were unplanned pregnancies. I think almost all HIV infections are unplanned as well. Anyway, just a point, an important point.
Thanks, Dave. So we're in the half hour. I don't want to take more time.
Florence, following up a little bit on the question that I asked before, maybe the postpartum is the, as opposed to the pregnancy, where I think the balance is less clear, at least to me, of safety. I mean, if you are not infected, and the chances of getting infected is, let's say, 1 in 100, and then your risk of taking, well, we can do the math, but I mean, the benefit is great. But in the immediate postpartum, so have you looked at the city data? I mean, I know that you have good collaborators in the city to see how new cases of HIV infections are happening among the women that get infected. How many of them had a delivery of a baby within a year of the diagnosis, of the new diagnosis of HIV? Because all of them would have been tested before if they had a pregnancy, because that's the standard of care. So how many infections are happening in the 1 to 3 years after the postpartum of the last pregnancy? Because that might be a good target if the incident is target for PrEP. PrEP isn't underutilizing women, but I think targeting the pregnant women might not, that don't have HIV already, might not. I don't perceive that as the right population to target for PrEP for women.
Yeah, no, I see where you're coming from, Pablo, because I think, again, there was a lot of concern about, well, I don't want to take a medication that I don't need to at this point, even, you know, just general perception that, you know, it's better just to protect the baby. The caveat to that.
Which PrEP are you thinking in using? There is no data with this COVID. Truvada produces bone loss in babies, and integrase inhibitors carry out some weight. So which one are you going to say is completely safe?
Yeah, well, the bone loss is not, I mean, after a year, that signal disappears for babies. But the advantage of using PrEP in pregnancy is that, again, you protect, is that, you know, that additional protection to the baby, right? I mean, you could make the case for breastfeeding women that the risk is there as well for the baby. But I agree with you. I don't have this data. I can ask Kathleen to, we can look at that. What I can say is that it's probably underreported because other than pregnancy, no, unfortunately, HIV testing in the postpartum period is not common because it's just not, you know, those women see their OBGYN at 6 weeks, they don't return to primary care. And so there's limited opportunity for testing. But it's still a very good question to see, you know, to look at the incidence postpartum.
It's also, I
Thank
mean, I'm
you.
sure you
We're
all
going to
know
have
this,
to move on because it's
just
already.
One last thing, physiologically, after you deliver that postpartum state, plus or minus breastfeeding is physiologically one of the highest risks for transmission, given the changes to hormones, to vaginal mucosa, cervical mucosa, etc. So it's a super high risk time period for people who may be re-entering, you know, sexual networks, etc.
Thank you. So we're going to move to the second part. Dr. Hamideh Parhiz from the Research Assistant Professor of Medicine, and she will be discussing with us T-cell targeted lipid nanoparticle platform for in vivo delivery of mRNA therapeutics. Go ahead. You want to share your screen?
Can you see my screen?
Yes.
Awesome. Thank you so much for the introduction. Yeah, today I will talk about development of a T-cell targeted lipid nanoparticle platform for in vivo delivery of mRNA therapeutics. I'm sure you heard a lot about LNP mRNA vaccines and probably also a lot about nucleoside modified mRNA, which we work with, and that's the basis for lots of mRNA vaccines now. So today I'm going to talk about, the second part of this story, which is LNP, lipid nanoparticle, which is the delivery system, and what actually we modified on this delivery system to make it applicable for different types of applications and diseases, including HIV. Lipid nanoparticles are one of the most promising carriers, I can say, or delivery systems developed so far for delivery of mRNA therapeutics. They are, as you can see in this picture and electron microscopy figures, they are a little bit different in terms of physicochemical characteristics compared to vesicles, lipid vesicles like liposomes. So they have electron-dense core, and that's because of the electrostatic, mainly electrostatic interaction between the lipid components and mRNA, or let's say another type of nucleic acid, in the core of these delivery systems. In this slide, I'm just trying to show that what they are made of, lipid nanoparticles. So lipid nanoparticles in general, they're composed of two categories of lipids. One of them, which is one of the most important part of a lipid nanoparticle, especially when it is going to be used for nucleic acid delivery, is an ionizable lipid. Ionizable lipid helps to condense and compact nucleic acid inside of these delivery systems. That's what we call encapsulation. So it will increase encapsulation efficiency of a nucleic acid. And then we have helper lipids, the lipids, that form the shape of LNP, like the SPC, and some lipids like pegylated lipids that extend the circulation time and have kind of a shielding effect on the surface of LNP. And then, of course, cholesterol, which has kind of a filler, role in LNP. And most of the LNPs, commercial LNPs, and the LNPs are made in academia, mainly actually composed of these four lipid components. Lipid nanoparticles, as I mentioned earlier, they are actually very efficient in mRNA delivery, not just mRNA delivery, different and several types of actually nucleic acids. And mainly, if you inject them IV, mainly they will target liver. And that's because because of the lipid composition, they can get lots of ApoE on the surface when you inject them IV. And then because of that, hepatocytes can actually take up these nanoparticles very efficiently. That's why if you inject most of commercial LNPs in vivo IV, they will mainly actually accumulate in the liver. The whole idea behind having a targeted platform was actually a huge amount of applications for mRNA outside, hepatic system. Or, for example, when you do vaccine and you do IM injection, you don't have any, you are not looking for any kind of targeted delivery. But there are lots of applications for mRNA that you want to have mRNA in a specific tissue, not just a specific tissue in a specific cell type. You want to send this mRNA to brain, lung, heart, not just, let's say, for example, a spleen, but CD4, for example, positive T cells. So that's why we started in 2016 to make this targeted mRNA LNP platform in a collaborative actually approach with Dr. Musikantov's lab and also Dr. Wiseman lab. So we developed this targeted platform first for endothelial cells and then we just expanded to different types of cells so far. So in this targeted platform, you have the core LNP with the mRNA encapsulated inside, and then you will just decorate the surface of this LNP with the antibody of interest or any type of targeting moiety against any type of cell that you want. So, so far we did this for different types of, endothelial markers. We did this for different types of T cell markers and also hematopoietic stem cell markers. What I'm going to talk about, just the basics of T cell targeted today. I'm sure lots of you know that if we can target T cells in vivo, and if we can manipulate T cells in vivo, that will have lots of applications. We can target infectious diseases like HIV. We can target, for example, cancer. We can do even very acute types of diseases, which I will actually mention one of them today, just to show you the potential of the system. So we saw actually lots of potentials and applications here. And this is kind of the basis for my CFAR Pilot Award that we first proposed to target CD4 T cells. And this slide actually shows what we were thinking at the beginning to do with these CD4 T cells. And of course, we just got distracted to do lots of other things, but that was the basis for this. So we wanted to target CD4 T cells to be able to deliver BREC1, that's a kind of recombinase enzyme, as mRNA to the T cells. This enzyme is believed to be able to actually excise the integrated porovirus. So we thought that, the strength of our targeted platform with this combined with this enzyme delivery in terms of mRNA can give us some tools to actually, to go towards cure HIV. And that was the purpose behind this actually proposal. So I'm going to show you some of the data that we produced so far. First, of course, for CD4 T cell targeted platform, we started with in vitro studies. And we tried just to target human T cells. So here in this slide, in A and B, you see the two of the experiments that we did on human T cells in vitro. So we targeted mRNA LNPs with anti-CD4 and then compared with control IgG. In figure A, these lipid nanoparticles are radio labeled. So we just tracked the radioactivity, and you can see the, targeting the binding, a specific binding to T cells with anti-CD4, but not control IgG. Control IgG doesn't have any specificity towards any kind of a specific marker. Then we moved to mRNA translation. So we wanted to know that, okay, these cells take up the mRNA, can they translate the mRNA or not? So we did luciferase assay, again in vitro, transfected human T cells with anti-CD4 targeted versus control IgG mRNA LNP, and mRNA that was encapsulated was luciferase, and we just tracked the luciferase activity in those cells. And again, we saw a specific targeting in terms of translation on human T cells. We then moved forward to in vivo studies. One of the first experiments we did in vivo, we just tracked, the biodistribution of these targeted versus non-targeted mRNA LNPs in vivo in black 6 mice. So we injected anti-CD4 versus control IgG, mRNA LNP, and here again, LNP is radio labeled, and we saw accumulation of targeted lipid nanoparticles in the spleen, which was actually which we know from the beginning that because it's the tissue that has lots of T cells, so of course we, if the delivery is successful, we can get accumulation in the spleen. And this is localization ratio that shows that particles are actually localized in the spleen when you compare to other organs. Again, move forward from just the tissue uptake to mRNA translation. We injected anti-CD4 luciferase mRNA LNP versus control IgG luciferase mRNA LNP IV in black 6 mice, and again tracked for luciferase activity in the tissue homogenate. And we saw, a spleen signal much stronger than control IgG. We also saw that because of the targeting, usually what happens when you target lipid nanoparticles to specific tissues or a specific cell type, you will decrease also the off-target effect, which is observed here also. So compared to control IgG, we have lower signal in spleen, in liver, and higher signal in spleen. These are some IVIS imaging, and you can see the same results with IVIS imaging as well. The luminescence signal from spleen here compared to in targeted LNP mRNA compared to control IgG. And this is a lymph node actually lit up here because of the injection of LNP mRNA. To have a kind of single cell resolution of the cells that are receiving these targeted lipid nanoparticles, we usually use AI6 mice. So in this mice, you have a Cree reporter allele, it's shown here. So you have a Lux P flank stop codon before ZS green. And if you deliver Cree recombinase mRNA into these mice, which this mRNA then will be translated to Cree recombinase protein. Cree recombinase protein can just excise this part, this stop codon, and then you will see ZS green signal, which we usually track with flow cytometry. So the more ZS green signal we see, it shows actually, the more Cree recombinase mRNA we could deliver. And if we can track this signal in a specific cell type, then you can see the targeting efficiency in those specific cell types as well. So that was the way that we wanted just to show that when we are saying CD4 T cell targeting, we are actually delivering to CD4 positive T cells. First, we did in vitro study. So we got a splenocyte from AI6 mice and incubated with control IgG, Cree mRNA LNP versus anti-CD4 and then unconjugated. And you can see at all of the doses that we tested from 1 microgram to 9 microgram, we could see a drastic increase in targeting with anti-CD4 targeted mRNA LNP compared to control IgG. At that time, actually, we thought that this 1 microgram is a very low dose, but these days we know that it's actually, compared to the recent studies we're doing, it's actually a very high dose. So we couldn't, with this figure, we couldn't show any kind of dose response because even at 1 microgram, we kind of saturated the signal. We then did some in vivo studies in AI6 mice. So these results show the percent of ZS green positive cells in CD3 positive, CD8 negative cell population, which means almost CD4 positive cell population. So we just wanted to show if actually our targeted versus control IgG giving a specific signal in CD4 positive T cells. And we saw among, all of those that we tested from 3 microgram to 30 microgram in this specific study, we saw a specific targeting with anti-CD4 targeted particles. We did also some doses, time point studies. So after 1 day of injection, 4 days of injection, and 7 days after injections, we just took, again, spleen and lymph nodes, and we tracked the screen signal. And we showed that, especially in spleen, we started with almost 60%, and then it goes down to above 20% of the cells. It's still above unconjugated and control IgG. For this specific experiment, we didn't move forward beyond this day 7. I want to jump to, it's a very different, actually, kind of a study that we did from this CD4 positive T cells, but I just want to show the potential of this system for other, applications. So one of the studies that we did, because we could show that we can target, CD4 positive T cells, so we just said that, of course, I think we can just target any other type of T cells. And we started thinking about using this platform for CAR T cell therapy, in vivo CAR T cell therapy. We did one of these applications with John Opstein lab at Penn, and I will show you some of the results. So these are some preliminary results we did for this purpose, just CAR T cell delivery, in vivo CAR T cell delivery. We used CD5 as a marker for these type of applications. First, we showed that we can achieve that specific targeting when we deliver anti-CD5 targeted LNP mRNA compared to control IgG. And then again in AI6 mice, we could show actually a specific targeting, and you can see there is not much difference between CD4 positive T cells and CD8 positive T cells that received anti-CD5 targeted mRNA LNP, which was the purpose. And then we did this application. So John Opstein lab, actually, they have extensive experience in cardiac fibrosis models. And in their previous studies, they showed that in different types of cardiomyopathies, right, there are some certain proteins that are overexpressed. One of these proteins at the top of this list is FAP, fibroblast activated protein. So here you can see human tissue that FAP is actually upregulated and overexpressed. And these are some of the mouse studies that they did. So in their cardiac fibrosis mouse model, they inject angiotensin 2 plus phenylephrine for about a week. And after 1 week, you can see fibrotic tissue actually in the heart, which is shown here. And then it is in correlation with FAP or FAP expression as well. So when we started talking about this project, we thought that our targeted LNP mRNA platform may have kind of application in this sort of studies that they're doing in a way that we can target LNPs against T cells, inject them in vivo, and these CD5 targeted LNPs can actually have mRNA expressing FAP-CAR to produce CAR-Ts against FAP in vitro. And that can probably resolve or help resolving the situation. I'm going to share some of the results. So these are the in vitro studies that we did. We just wanted to know that if we can express FAP-CAR. So here is FAP-CAR expression in vitro with CD5 targeted LNP FAP-CAR. And this is the percent FAP-CAR positive cells, which you can see is above 75%. And this is the killing efficiency when we make these CAR-Ts here, I mean in vitro, if they can actually kill the target. And this is the killing efficiency. You can see it's significantly higher than, for example, CD5 GFP, which doesn't have the FAP-CAR mRNA, or control IgG, which doesn't have the target. We also did some in vivo studies. Of course, I'm not a cardiologist, so I'm just trying my best to explain this. When you have a PBS condition, I mean untreated, you can see the fibrotic tissue as pink tissue here. And when you have your therapy in this model of mice, you can see that actually fibrotic tissue significantly decreased with anti-CD5 targeted LNP FAP-CAR mRNA. And these are some of the echo data. So basically, they show that we could improve cardiac function as well. So these are, for example, end diastolic volume, that this is the diseased condition. and we could actually lower it to kind of a naive condition. The same with end systolic volume as well, ejection fraction, or some of the parameters that shows the strength of muscle contraction capabilities of heart muscle. So with all of these, we could show that this T-cell targeted LNP mRNA platform may have also, some potential in using for in vivo CAR T-cell therapies. Just to summarize this, I just wanted to show that the platform that we made may have some application in infectious diseases like HIV by, for example, delivering BRCA1, which we are doing now. We are trying to optimize the BRCA1 mRNA construct that we have, and hopefully we can get some therapeutic efficiency with that. Also, we can expand this to CAR T-cell therapies for both HIV or other, type of disorders and applications. I want to thank all of, actually, my colleagues. This definitely was a collaborative efforts in Drew Weissman lab and also Vladimir Muzikantov lab, Istvan, Dorothea, and all of other people who helped me with this project, and Jonathan Obstin lab also, especially Joel and Haig, who helped on the cardiac fibrosis model, and of course CFAR, who provided the pilot grant that we could perform lots of basics of these experiments with that model. Thank you so much, and I'm ready to answer any questions.
Thank you.
Can I ask a question?
Sure, of course.
That was a nice talk. Can I ask kind of a basic question, and I apologize if this is obvious, but when you're designing your targeting strategies, do you have to target specific cell surface receptors that are involved in cell entry and endocytosis, or can you just get your lipid nanoparticle to the cells or the tissues that you want, and then the rest kind of happens in that way?
Yeah, that's a really good question. If you want to have a kind of ideal targeted delivery system, yes, it's good to go for the receptors that you can have endocytosis after that. But some of these LNPs, I mean, very, very low amount of them can also fuse with the cell membrane. When you get them to the cell of interest, it can happen, but I don't think that's actually very efficient method of delivery.
Hey, I have a question.
Sure.
It's such cool technology, and the cardiac fibrosis stuff is also really fascinating. I'm wondering, so you talked about targeting T cells, CD4 T cells, and it looked like you were able to get some reasonable specificity in some tissues, although there's still a lot of nonspecific liver uptake. Yeah. I wonder what you're doing next with this from the CFAR point of view in terms of targeting T cells. You didn't mention how you're going to tweak that, or what comes next for that.
Yeah, actually that's a really question. So we are trying to focus on two actually kind of directions and approaches. One is to focus on applications of this targeted platform, and second is actually what you mentioned on optimizing the targeted delivery platform. So we're trying to have to change this targeted platform in a way that we have less amount of off targets, and also switching from, let's say, whole length antibodies to antibody fragments, which at the end of the day will give us less amount of off target effects.
And still looking at CD4 as your antibody for targeting, or
no
other?
No, we have actually lots of targeting moieties now in hand. We have CD5, we have CD4, we have hematopoietic stem cells, which we could show actually we have really nice targeting in hematopoietic stem cell targeting with just injecting in IV. And we still have, endothelial targeted platform, other immune cells like B cells, endothelial cells.
Right, although they're not HIV targets, the B cells.
Yes, exactly. Yes.
Thanks.
Thinking about the HIV flavor and have you thought about, Khalili's group is giving CRISPR to try to size the reservoir using the CRISPR technology, and they give it with AAV and basically trillions and trillions of viruses to infect every single cells in the body. Have you tried to target CRISPR and see if you could size by targeting CD4s? Yes, as a model. I don't think in vivo, I think all this is more questionable. But in vitro, if you have a cell line that is clearly with virus integrated, can you use this delivery system to target and size the HIV specifically with a CRISPR approach?
Yeah, we have a program on CRISPR approach. But not specifically on HIV. So to answer your question, for HIV, no, we didn't do it. But we did do several, CRISPR experiments, specifically in vitro. And when it comes in vivo, we mainly did knockout studies. So we're trying to get knock-in works, but we didn't do any of this for HIV yet.
Yeah, but there is a humanized mice of HIV. There is the CRISPR sequences by Khalili's paper. You have the method to deliver them, particularly against CD4. So it seems like the next experiment, I know it's very easy for me to talk from a desk that is not wet. But yeah, I think if you want to keep the HIV connection.
Yes, I completely agree with you. I don't know if there is any question in the chat.
Yeah, I think if we are successful in the expected recompetition of the cure, Delaney, this is something that we definitely want to revisit relative to the HIV connection. Because we do have the humanized mouse, we do have pretty much everything in-house to pursue this.
Yeah, you have.
And the non-human primate, hopefully in the future as well.
You have the nanoparticles. You just need to put the right enzyme and do the experiment. I don't think your jump to humans is far away, but that is.
If anybody interested to do, any collaborative projects, of course, let us know, and we will definitely be glad.
Yeah, we will. You can reach out. I will reach out to you as well. We can start talking about it.
Awesome.
Like I said,
with this technology, there's a lot of things to do.
Yeah.
Awesome. Thank you so much.
All right. Well, thank you everyone for joining. This has been very productive. So thank you for your time.
Thanks so much.
Bye.